This is another example. These three lesions together can be called irregular in shape. Looking on the first lesion, it has spiculated margins and it is of high density, and actually this was a carcinoma. The second lesion is also irregular in shape, but it has microlobulated margins. It's of higher density than the surrounding breast tissue, and it was another carcinoma. And the third lesion had obscured margins, and it is of equal density to the surrounding breast parenchyma, and actually this was a fibroadenoma. And now we move to the calcifications morphology descriptors. And whenever we find calcifications in the breast, we are asked to describe both the morphology and the distribution of the calcification. Looking at the morphology, we have the benign calcifications of intermediate concern and suspicious calcifications. And in the new BI-RADS lexicon, because we manage the intermediate and the suspicious calcifications in the same way, they remove the intermediate group and we are only left with the benign and suspicious calcification. Under the benign calcifications, we have a long list. And what changed in the new BI-RADS lexicon is that they removed the lucent-centered and the eggshell calcifications, and they are both included under the title rim calcifications. And one common feature which combines all benign calcifications is that they are all macrocalcifications. And if we look at the suspicious calcifications, we have the fine pleomorphic, the fine linear, and the fine linear branching, and the two other types which were previously called of intermediate concern, the amorphous and the coarse heterogeneous. And again, one common feature which combines all suspicious calcifications, with the exception of the last type, that they are all microcalcifications. And then we have to describe the distribution. The calcification might have a diffuse distribution, a regional, a grouped, which we formerly called clustered calcifications, and the linear and segmental distribution. And going from up to down in the distribution, we are moving from a benign to a malignant type of calcification. And now we'll see examples for the benign calcifications. This is the skin or the dermal calcification. These are the vascular calcifications. This is the popcorn calcification, which is typical for an involuted fibroadenoma. And these are the rod-like calcifications, which we find with the plasma cell mastitis. These are the rounded calcifications. These are the dystrophic calcifications, which are usually present in operative beds with fat necrosis. This is the milk of calcium calcification, and this is the rim calcification, which is characteristic for the oil cyst. And now we see examples for the suspicious calcifications. They might be fine pleomorphic calcifications, fine linear branching, amorphous, which have different shapes and sizes, and the coarse heterogeneous calcifications. And now we'll have examples for the distribution of calcification. This is the diffuse pattern of calcification. These are regional calcification, which occupy more than one quadrant of the breast. This is the segmental calcification, which follow the ramification of ducts. These are the grouped, which we used to call clustered calcifications, and these are the linear and the linear branching calcifications. And now we finished with the mass lesions, with the calcifications, and now we move to the asymmetry morphology descriptors. And if we ask how do breast asymmetries look like, we can simply answer they look like nothing. They lack the convex borders of masses and are often interspersed with fat. They also lack the radiating lines or tissue retraction of architectural distortion, and they lack the tubular branching appearance of a dilated duct. We formerly classified the breast asymmetries into global and focal, but now we have four subtypes. We have the simple or single view asymmetry, global, focal, and developing asymmetry. And actually, again, going from up to down, we are moving from a benign to a malignant asymmetry. We'll start by the simple asymmetry, which is called the single view asymmetry. And the single view asymmetry is only seen in one mammography view. They usually contain interspersed fat, and they are usually caused by superimposition of normal fibroglandular breast tissue, and therefore most simple asymmetries are benign in nature. The global asymmetry, on the other hand, is an asymmetry which occupies more than 25% of the breast, or at least one segment of the breast, and it is seen in two views, and it usually requires record for further assessment. The global asymmetry is 50% benign and 50% malignant, and what raises a suspicion in a global asymmetry is the presence of an associated palpable mass lesion, breast erythema or edema, calcifications or distortions. Here we have an example of a global asymmetry. There is a global asymmetry in the left breast which occupies more than one quadrant. But actually it is not a simple global asymmetry because it is associated with skin thickening and with pathological axillary lymph nodes. In these cases, we have to recommend for further ultrasound examination, and actually the ultrasound showed a diffuse edema pattern of the breast. There is skin thickening, edematous echogenic fat lobules, and interstitial edema lines, and we had hugely enlarged pathological axillary lymph nodes, and no masses were identified. And the diagnosis in this case was a case of inflammatory breast carcinoma. Moving to the focal asymmetry, which is the third type of asymmetries, and it is an asymmetry which occupies less than 25% of the breast. It is seen in two views, and it may be benign or malignant, but the incidence of malignancy is higher. As we did in the global asymmetry, we have to do another imaging modality to evaluate the focal asymmetry. And in this case, we performed 3D digital tomosynthesis, and it appeared more like a mass rather than a simple asymmetry. And this was the ultrasound examination, which proved that it is an intracystic papillary growth, and this was the contrast-enhanced mammography of the lesion, which showed enhancement of the solid component, and actually the pathology was malignant in this case. And now we come to the most serious of all asymmetries, and that is a developing asymmetry. And the developing asymmetry is either a new asymmetry or an asymmetry which has increased in size when compared with previous examinations. For example, we have this as the 2006 examination, and this is the 2008 examination. And we notice here that the patient has developed a new right retroareolar developing asymmetry. An ultrasound was requested, and an underlying carcinoma was identified. And we also, when looking at the mammography, we have to report special cases. For example, if we have a single dilated duct, this is one sign which is of concern. We have here a single or focally dilated right retroareolar duct. An ultrasound was requested and revealed a large intracystic papillary growth which showed increased vascularity. And actually, this was an intraductal papillary carcinoma. We have to also report if we have associated skin lesions. For example, this is a dermal mole. We have to report intramammary lymph nodes, and we have to comment on associated findings. For example, skin retraction, skin thickening, nipple retraction, or coarsened trabeculae, which might indicate the presence of an inflammatory process within the breast. And now we've finished with the lexicon of morphology descriptors, and we're moving now to the reporting structure with the final assessment categories. And a good mammography report should include an indication for examination, the description of the overall breast composition, a clear description of any important finding, a comparison to previous examination, a final assessment category together with a recommendation for action, for management. Looking at the overall breast density, formerly we used to describe the breast densities as an ACR 1, 2, 3, and 4 according to the percentage of fibroglandular tissue within the breast. But because this is a subjective assessment, and because the categories 1, 2, 3, and 4 got mixed up with the BI-RADS category, this has changed, and now we classify the breast density into ACR-A, ACR-B, and ACR-C, and ACR-D. And we are asked to write, after saying that it is, for example, an ACR-A breast density, we should write that this is a predominantly fatty breast parenchyma. And the reason why we write the breast density in the mammography report is because as we move from an ACR-A to an ACR-D breast density category, both the sensitivity and the specificity of mammography decreases. For example, here, because we have a predominantly fatty breast parenchyma, every one of us can easily diagnose the small carcinoma within the left breast. While on the other hand, if we see this heterogeneously dense breast, even if we know that there is a carcinoma, this is the contrast-enhanced mammography of the same patient. She has a large carcinoma, and we also saw the mass on the ultrasound examination, yet we cannot identify where the location of the lesion is on the normal mammography study. We have to compare also with, when writing the report, we have to compare with the previous examinations. For example, we have this lady, she performed a conservative surgery in the left breast, and this is a normal appearance after surgery. There is diffuse edema with skin thickening and coarsened breast trabeculae, and nothing more. And in her next year examination, the edema pattern resolved, the skin has become much thinner, and the coarsened trabeculae have cleared, but unfortunately she developed this mass lesion at the operative bed, and an ultrasound examination revealed an underlying carcinoma. At the end of the report, we should give a BI-RADS assessment category to the lesions we have seen during assessment of the mammography. And the BI-RADS assessment categories are designed in such a way to be concordant with the specific management recommendations. We should include the text corresponding to each category, which means that if we write a BI-RADS 0, we should say that this is an incomplete assessment that needs additional imaging evaluation. If we write a BI-RADS 1, we should say that this is a normal examination, and the BI-RADS 2, we should say that these are benign findings, and in both we recommend for routine mammography screening is recommended. A BI-RADS 3 is a probably benign lesion that needs short interval follow-up, and the BI-RADS 4 with its 3 categories is a suspicious lesion that needs biopsy, and the BI-RADS 5 is a highly suspicious of malignancy with an appropriate action should be taken, and the BI-RADS 6 lesion is a pathologically improved lesion, a malignant lesion, for example, a patient undergoing neoadjuvant chemotherapy. There are some points also that needs clarification concerning the BI-RADS assessment categories in the new BI-RADS lexicon. Although the linking of assessment categories with concordant management recommendation further enhances sound medical practice, yet in the new BI-RADS lexicon we are allowed to uncouple the assessment categories and management recommendations in some selected cases. For example, we might have a lesion which is categorized as BI-RADS 3 category, but the patient is a high-risk patient, or the patient or the clinician insists on doing a biopsy. We keep it a BI-RADS 3, we do not raise it to a BI-RADS 4 category, and then we recommend a biopsy for this case. But it's, of course, it's unaccepted at all that we say that the lesion is BI-RADS 4 and 5, and then the recommendation comes as an annual follow-up examination. We have also some points to clarify as regards each of these categories. For example, the BI-RADS 0, they said that it should be used only in screening. And if used in diagnostic context, it should, it can be only used in the diagnostics context when complementary examinations are not immediately available. A BI-RADS 2 is limited to specific lesions on screening. If we have an involuted adenoma with the typical popcorn calcification, if we have a fat-containing mass lesion or benign, typically benign calcifications, if we have intramammary lymph nodes and post-operative sequelae. The most problematic group is the BI-RADS 3, and it is said that if we are doing a follow-up for a BI-RADS 3 lesion and we find that the lesion is increasing in size, we should immediately recommend a biopsy. And it should be used only for circumscribed solid masses, focal asymmetry, or solitary group of punctate calcification. And actually there is debate concerning the use of BI-RADS 3 in screening, because some say that it leads to unnecessary biopsies and others say it might delay diagnosis of breast cancer. And therefore we should conduct a complete diagnostic imaging evaluation before using it in screening programs. And the BI-RADS 4 and 5 categories should be given only in screening programs after we complete the full diagnostic imaging workup. And to end my lecture, using the standardized mammography descriptors and the BI-RADS final assessment categories have proved to be a unique resource for measuring and improving the quality of mammography interpretation. It provides an important assessment tool to audit interpretive performance, and establishing a clear line of communication between the radiologists and referring physicians is crucial to improve quality patient care and is very useful in clinical research. And thank you.
Thank you, Professor Rasha, for your nice talk. Thank you for your well-arranged knowledge. And now the second talk by Professor Rasha, MRI of benign and malignant lesions.
Sorry, if I bore you by the long talks. Bismillah ar-Rahman ar-Rahim. My second lecture will be MRI of benign and malignant breast lesions. Over the past few years, there has been significant development in the investigation and management of breast cancer. Because it was found that the only way to curtail breast cancer is by coupling early detection together with a proper diagnosis in order to be able to give the patients the most adequate and appropriate treatment options. And of course, we as radiologists play a fundamental role in this part. And speaking about detection and diagnosis, we should be able to discriminate between both terms. While detection is what we actually do in screening programs, and that means finding unsuspected pathologies, diagnosis means classifying these pathologies into benign and malignant. And everyday innovations in the field of breast imaging are heading to find an ideal breast imaging modality that can combine excellent detection capabilities together with excellent diagnostic capabilities. And we have long been coupling mammography for detection together with ultrasound for diagnosis in order to yield the best outcome. And when MRI was first introduced in the field of breast imaging, it was thought that it will play its major role in the diagnostic context. But actually, until recently, the ACR has recommended the use of MRI in detection or in screening programs, especially in screening high-risk individuals, and I will discuss this in my lecture tomorrow. As a detection modality, MRI, as I've said, is used in screening of high-risk individuals, and as a diagnostic modality, it is used as a problem-solving imaging technique in inconclusive mammography findings, in the pre-operative staging, whenever we have metastasis of unknown primary, to monitor chemotherapy in the post-operative breast, and when we have breast implants. One major advantage of contrast-enhanced MRI also is that it is one of the few breast imaging modalities that couples both morphology assessment together with functional information. And under the heading of the morphology assessment, we're going to discuss today the MRI morphology descriptors, and under the functional information, we're going to discuss the kinetic curve analysis in an attempt to differentiate between benign and malignant breast lesions. And in the second part of my lecture, we are also going to discuss, like the first lecture, how to write an MRI report. We will start by giving a brief hint about the technique of MRI. And in MRI imaging, we usually do pre-contrast and post-contrast pulse sequences. In the pre-contrast pulse sequences, we usually take the axial T1 weighted images, the axial T2 weighted images, the axial T2 stir images, and the sagittal T2 weighted images. And we usually plan the axial slices on the sagittal localizers, and then axial images look exactly like the CC views of the mammograms. And we plan the sagittal images on the axial localizer, and actually the sagittal images look like the mediolateral view of the mammograms. And then after that, we inject gadolinium at a dose of 0.1 millimole per kilogram body weight, and then we take a sequence of images starting from the 0 minute, in which we have no contrast, starting by 1 up to 8 minutes injection. And if we imagine that this, look at this is the T1 weighted image, and this is the post-contrast T1 weighted image, I think it is very difficult to identify enhancing white lesions within this enhancing white breast parenchyma. And that's why when we see the post-contrast images, we usually see it either in a fat suppression or in the subtraction mode. The fat suppression actually is a generic term, and it depends on the fact that the hydrogen nuclei of fat and water resonate at different frequencies, and therefore it is possible to selectively excite or suppress just the fat. While image subtraction is removing the background signal from pairs of pre- and post-contrast images, and much of the background signal is actually due to fat. If we imagine that we have here an enhancing lesion which is present in a whitely enhancing breast, it's very difficult to identify the enhancing lesion. But if we subtract the non-contrast image from the contrast image, then we are left with the newly enhancing lesions among the subtracted breast parenchyma. And looking on how lesions behave on MRI, we will find that we have a long list of benign non-enhancing lesions, and we also have malignant lesions which do not enhance, and the most eminent of which are the DCIS with non-invasive component. And we also have, besides the malignant lesions, we have a long list of benign lesions together with normal enhancing tissues on MRI that show contrast uptake. And because we have an overlap between the enhancing and the non-enhancing lesions in benign and malignant breast lesions, it has become essential to describe both the morphology descriptors and the kinetic curve analysis in order to be able to discriminate between benign and malignant breast lesions. And now we're finished with the MRI technique. We have 6 to 8 films in hand, and when we feel we are in a mess, where to start looking and what are we looking for? But we all know that enhancement of a lesion on MRI depends on its neovascularization, and it is rare to find non-enhancing malignant mass lesions. And so it's logic enough if we start by looking on the post-contrast subtraction or the fat suppression films. And when we look on the post-contrast films and we find no enhancement, we have a little job to do. We just have to go back to the T2 and the T1 weighted image just to try to characterize the lesion, the non-enhancing lesion. But if we have an enhancing lesion, we have a long job to do. We have to assess to describe the morphology descriptors. We have to measure the kinetic curve analysis, and we have to look for the T2 and T1 weighted images. And remember, doing all this, we should never forget to have the mammography in hand, because as we said, we have malignant lesions which do not enhance, but they appear clearly on the mammogram, like the DCIS, which shows the microcalcifications which would never be appreciated on MRI unless we have the mammogram in hand. And actually, this will be our scheme in discussing how we manage lesions or differentiate between benign and malignant lesions on MRI. We will start speaking by the morphology descriptors, then the kinematic curve analysis, and then we will look at the T2 and the T1 weighted images. And now we'll start by the morphology descriptors. And according to the MRI lexicon, enhancing lesions should be classified into a focus, a mass, and a non-mass enhancement. And when we have enhancing foci are actually lesions which are less than 5 millimeter. They are not space-occupying lesions, and they may be single, and when they are identified, we should measure the time signal intensity curve just to exclude that it is an early tiny carcinoma. And they may be multiple foci, and according to the new BI-RADS lexicon, multiple enhancing foci are included under the background parenchymal enhancement, and we will discuss this after a while. Now moving to the enhancing mass lesions. And enhancing mass lesions are three-dimensional space-occupying lesions. They, as we said before, they might be benign and they might be malignant. And therefore, according to the MRI BI-RADS lexicon, to characterize enhancing mass lesions, we should describe the shape and the margins and the internal enhancement characteristics of these lesions. Looking first at the shape, when we say the lesion is rounded or oval, we're most probably speaking about a benign lesion. And when we say that the lesion is irregular, we're most probably describing a malignant lesion. And looking, we used to have the lobulated form, but now it is removed from the new BI-RADS lexicon. And then we have to describe the margins of the lesion. And when we say that the lesion has circumscribed margins, that means we are most probably speaking of a benign lesion. And when we have not circumscribed margins, which might be either speculated or irregular, then most probably we are describing a malignant lesion. And then we have to look on the internal enhancement characteristic of lesions. And we might have a homogeneous enhancement or dark internal septations, which are descriptors of benign lesions, and we might have heterogeneous enhancement or the rim enhancement pattern, which are descriptors of malignant lesions. And now, putting things together, if we have an enhancing mass lesion, it might be benign, it might be malignant, so we have to describe the shape, the margin, and the internal enhancement pattern. If we have an all-rounded or an oval shape with circumscribed margins, homogeneous or with dark internal septations, we're dealing with a benign lesion. If we have a regular shape, not circumscribed, whether the irregular or the speculated, that shows heterogeneous or rim enhancement pattern, we are speaking of a malignant lesion. But we have to remember that we are not always working by the book. For example, we have this lesion. It can be classified as rounded. It has speculated margins, and it shows homogeneous enhancement. Which should we take? Should we take with the rounded and the homogeneous and say it's benign, or take with the speculated margins and say it's malignant? We usually take by the worst of all signs. So we put aside the rounded and the homogeneous pattern, and so long as the lesion is speculated, that means it is malignant. And now we move to the third group, and that is the non-mass lesions. Non-mass lesions is an area of enhancement. It's non-space occupying. And again, non-mass lesions can be benign and can be malignant. And to characterize non-mass lesions, according to the MRI Beirat's lexicon, we should describe the distribution, the symmetrical or being symmetrical or non-symmetrical, and we should describe the internal enhancement patterns. And to start with, bilateral symmetrical non-mass enhancement is almost always benign. It usually describes enhancing breast parenchyma, and we will discuss this later under the term the background parenchymal enhancement. While if we have asymmetrical or unilateral distribution of non-mass enhancement, we have to describe the type. It might be focal, it might be linear, it might be segmental, it might be regional, it might be multiple regions, and it might be diffuse enhancement. And actually, asymmetrical non-mass enhancement is almost always of concern because they usually indicate an underlying ongoing pathology, whether benign or malignant. And then we have to look on the internal enhancement pattern of non-mass lesions. It might be homogeneous, heterogeneous, a clump pattern of contrast uptake or clustered ring appearance, and with the exception of the homogeneous enhancement, the other three types usually indicate malignant enhancement. And now we're finished with the morphology descriptors of the focus, the mass, and the non-mass, and then we move to the kinetic curve analysis. Whenever we find enhancing lesions on MRI, we are asked to measure plot the time signal intensity curve. And the time signal intensity curve has two components. It has an initial phase, which might be slow, medium, or fast, and it has a delayed phase, which might be persistent, plateau, and wash out. And in between the initial phase and the delayed phase, we have the contrast peak, which is usually reached at about 3 to 4 minutes. We have several types of time signal intensity curve. We have the type 1 curve, which is this curve, this light violet curve. It's a continuously rising curve, and it usually indicates benign lesions. While the green curve, it is type 2 curve, and this is borderline. It's 50% benign, 50% malignant. And the type 3 washout curve is a typically malignant curve, and the type 4 curve is for the enhancing parenchyma. It is a low peak, continuously rising curve. And now we're finished with the kinetic curves. We have to go back to the T2 and the T1 weighted images. Actually, the T2 weighted image is often used as a problem solver sequence, since it provides additional relevant information on different breast lesions, narrowing down the differential diagnostic considerations. A bright signal on T2 weighted image is usually good news. It might be a cyst or a fat necrosis. While only colloid carcinomas appear bright on T2 weighted image, and they can be differentiated from a cyst by the contrast enhancement on the contrast images. While on the other hand, if we have a dark signal on T2 weighted images, it usually carries bad news for a malignant process. We will give one example of how the T2 weighted image can be used as a problem solver in MRI. For example, we have these two lesions. We have here a rim enhancement in these two lesions. Should we go directly and say that rim enhancement is a sign of malignancy and these two lesions are directly malignant? Actually, we do not do so. We correlate what we see here with the T2 weighted image. If the lesion shows a dark signal on the T2 weighted image, then it is a malignant lesion. And if it shows a bright signal on the T2 weighted image, then it might be a cyst, an infected cyst, or an abscess cavity. Another example is this. This was a young female. She came with inflammatory signs of the left breast. She has skin thickening, and she has a subtle segmental contrast uptake, which is more appreciated in the color-coded images. The time signal intensity curve in this case was a continuously rising type 1 curve, which is characteristic for benign lesions. And again, should we go here directly and say this is a benign lesion? No, we should go back to the T2 weighted image, and we see the corresponding area to enhancement. Actually, the lesion on the corresponding to the area of enhancement was not bright. It was dark on T2 weighted images, and actually this was a very early case of inflammatory breast carcinoma. We should also comment on other findings, like this case. We have skin thickening, nipple retraction with a retracted breast. We should comment on if we have pathological axillary lymph nodes, if we have an operative bed fat necrosis or operative bed seroma, and if we have large enhancing lesions that might invade the pectoral muscle. And remember what I told you in the beginning of the lecture, always have your mammogram in hand. For example, this was a female patient. She came for screening, and unfortunately we found she has a newly developed microcalcific cluster in the upper outer quadrant of the left breast. Her MRI was not very informative because she had a diffusely enhancing parenchyma, and if it was not that we see this linear enhancement corresponding to the area of microcalcification, we could have easily missed the diagnosis. We should mention also the use of MRI spectroscopy as a potential impact for improving the MRI specificity. Because in spite of the fact that MRI shows high sensitivity, its specificity remains relatively low. Studies of experimental breast tumors have shown that choline is elevated in malignant lesion, and the raised choline values may be detected in vivo using single voxel spectroscopy. For example, we have this case. She has a very well-defined mass lesion. It shows homogeneous contrast uptake, and it shows dark internal septations. And on her T2 weighted images, the lesion appeared of intermediate to bright signal, which gave us the impression that it might be a benign lesion. But during the MRI spectroscopy, she had a high choline peak, and she was sent for biopsy, and actually this was an invasive duct carcinoma. We should also comment on the diffusion-weighted imaging, which provides a novel in MR imaging, and it has a high sensitivity in the detection of changes in the local biological environment. A significant advantage of diffusion-weighted MRI is its high sensitivity to changes in the microscopic cellular environment without the need of intravenous contrast material. In diffusion-weighted images, we usually comment on three things. We usually comment on the diffusion-weighted images, we measure the ATC value of the lesion, and we look back at the T2 weighted image. For example, we have this lady. She's a 47-year-old female. She presented by a palpable left breast mass. Her mammography was inconclusive. She had a heterogeneous dense breast parenchyma. But on her MRI, we found this enhancing lesion, which showed a dark signal on T2 weighted images. And for the first look, we thought it might be benign, and we thought that this irregularity in the wall was merely due to the enhancing surrounding parenchyma. Her time signal intensity curve was a type 2 curve, which is 50% benign and 50% malignant. We did a diffusion-weighted imaging at values of B0, 50, and 850, and actually the lesions which show a bright signal on all sequences here and here and here on all B values is usually called a lesion of restricted diffusion, and it means that this lesion is most probably benign. And then we measured the ATC value of the lesion, and it was low. Lower lesions with lower values than 1.2 are also considered malignant. Finally, we will give a hint of how to write a structured MRI report. The MRI report should include an indication for the examination, the technique of the MRI, a description of the overall breast composition and the background parenchymal enhancement, a clear description of any important findings, comparison to previous examination, a final assessment category, and the recommendation for management. And actually, we have discussed 3 points, and we are left with 4 points that we will go on quickly. As a description of the overall breast composition, breast densities should be described as either entirely fatty, we have scattered fibroglandular densities, heterogeneous fibroglandular, and extremely fibroglandular. And we should also comment on the background parenchymal enhancement, which ranges from a minimal to a mild to a moderate and marked. And like we said in mammography, the reason that we have to comment on the background parenchymal enhancement is that the sensitivity and specificity of MRI decreases as we go from the minimal to the marked. And we should always remember, as I told you in the beginning of the lecture, that the background parenchymal enhancement should be bilateral, symmetrical, and diffuse. We should compare with previous studies. For example, we have this young lactating female, and that's why her breast parenchyma is extremely dense. She had a large, locally advanced left breast cancer with skin thickening and coarsened trabeculae. And then we measured the time signal intensity curve. We have a type 3 malignant curve, and she was a candidate for neoadjuvant chemotherapy. She took her neoadjuvant chemotherapy. She came for a follow-up. The breast edema has relatively resolved. The skin has become thinner, and the mass lesion has nearly disappeared. And if we didn't have the original films, we could never compare between the pre and the post-chemotherapy examination. And the last thing is that we have, at the end of our report, to write a BI-RADS category with a recommendation. Like what we said in mammography, but here we have very few changes. For example, if we say a BI-RADS 0, that's an incomplete assessment, and we can go for a targeted ultrasound assessment. A BI-RADS 1 and BI-RADS 2, we have normal and benign findings, but we do not recommend annual MRI in all patients. MRI would be here recommended only for high-risk patients annually. A BI-RADS 3 is like the mammography. We recommend for a short interval follow-up. A BI-RADS 4 is for biopsy, and the BI-RADS 5 is also for biopsy. And a BI-RADS 6 is like the case that we saw at the end of my lecture, and it is a biopsy-proven malignancy under neoadjuvant chemotherapy. And thank you.
Thank you, Professor Rasha, for your nice presentation. And now we'll open the session for questions. We are already have exceeded the time. Any questions for Professor Rasha? No questions? Any questions for Professor Nagla Abdulrazak? No questions? Okay, Dr. Scaparotta, any question for him? Okay, now I think we have gone beyond our time, so we'll end the session today, and now we'll be back at 2 o'clock for the second session. Thank you very much.